Hello everyone and welcome back to my playlist of pathology. We are doing chapter number 20 from Robbins, medium Robbins और endocrine disorders का ये chapter है. We are dealing with thyroid gland at the moment. उसके neoplasms discuss कर रहे हैं और benign neoplasm यानी कि adenoma already हम बात कर चुके हैं. Today we are going to focus on carcinomas. So basically our topic today is going to be thyroid cancers. Okay. Now, detection of small, clinically asymptomatic cancerous nodules of thyroid gland has increased dramatically. So, patients now coming with thyroid nodules are more often to be, neoplastic. At least in the United States over the last few years, largely due to increasing use of thyroid ultrasound and other imaging studies. So, that's an important point to actually have a look at. Because of these imaging studies, the incidence of thyroid cancers has been increasing. At least in the United States. उस पर भी deaths from the thyroid cancer have remained relatively stable during this period, underscoring the favorable outcome of such incidentally detected thyroid carcinoma. So, although it's increasing in its incidence prevalence, but mortality has not been increasing greatly, okay? A female predominance has been noted amongst the patient who developed thyroid carcinoma in the early and middle adult years, so female preponderance. By contrast, cases seen in childhood and late adult life are distributed equally between males and females. So the distribution is like this, okay? Particular age group में female preponderance है और उसके बाद it is male and female equal ratios. Most thyroid carcinomas, except one, अभी इसके बारे में हम पढ़ेंगे, are derived from thyroid follicular epithelium. So जो follicles हैं, उसकी जो lining epithelium है, they are follicular derived cancers. One exception to this rule being the medullary carcinomas, which usually do not derive from the follicle cells. The major subtype of thyroid carcinoma and relative frequencies are as follows. So these are the four names that you have to remember. और इन्हीं चारों के बारे में आज की वीडियो में we have to cover कि इनके salient features क्या हैं and how to approach questions related to each one of them. So as you see from the statistics, the most common one are the papillary carcinoma, which account for more than about 85% of the total thyroid cancers. Then we have next in line the follicular carcinoma, 5 to 15% of all the thyroid cancers. Then we have anaplastic and medullary, okay? They are 5 or less than 5% of all the thyroid cancers. So papillary, follicular, anaplastic, and medullary, okay? So ये चार नाम आपने याद रखने हैं because thyroid cancer में अगर ये नाम नहीं याद तो फिर और क्या याद है? Because of the unique clinical and biological features associated with each one of them, they are described separately. So अभी in the video today, we will focus on each one of them और हर एक का कोई ना कोई characteristic feature है, so वो हम discuss करेंगे, ठीक है? अभी जो हम बात कर रहे हैं, that is the generalized pathogenesis of all these cancers. So distinct molecular events are involved in pathogenesis of the four major variants of thyroid cancer, and these genetic alterations in the three follicular cell-derived malignancies are clustered along two oncogenic pathways that lie downstream the factors. और वो जो pathways हैं basically growth factor receptor pathways और RAS pathways. So ये pathways जो हैं mutated होते हैं for thyroid cancers. And further down these pathways, there are mitogen activated protein kinases and PI3 AKT pathway. They are all linked. So basically, if you have to answer what are the major mutations noted in thyroid cancers, they are basically pathways of growth factor receptors and RAS pathways. Okay, so that's an important piece of information for you, right? So if you look at this diagram, this tries to give you an overview that how RAS pathway is then downstream, regulated by different proteins. So for example, RAS pathway feeds into PI3 kinase, PTK1, AKT, and gene expression for growth differentiation and all these things. So if, for example, there are mutations at particular points, so for example, if there's a point mutation in a particular region of the RAS gene, it may lead to follicular and anaplastic carcinoma. BRAF, papillary carcinoma, also if there are some translocations in the chromosomal numbers, we'll talk about them, it may lead to follicular carcinoma. So that's a very important diagram telling you कि different जगहों पे जहाँ mutations हो रही हैं वहाँ PI3 kinase mutation, for example, also has been linked with follicular and anaplastic. So specific mutations, specific type of thyroid cancer increase risk, okay? In normal cells, these pathways are transiently activated by growth factor receptor binding only. कि अगर growth होनी है यानी ये जो जीन्स अल्टीमेटली एक्सप्रेस हो रही हैं, they have the job to do growth and cell differentiation. So upon binding of a specific receptor per specific ligand, then only the pathways are activated. However, in thyroid carcinomas, which result in signal transduction, increased activation, और ये दूसरे solid cancers में भी ऐसा होता है, there is gain of function mutation in the component of these pathways. So for example, that's a component of the pathway. That's the component of the pathway. So if there is increased mutation, they perform their function more. They have gain of function mutations and cancer results. Okay. So particularly papillary thyroid carcinomas में ये जो अभी हमने यहाँ पे बात की, that's going to be detailed here. So BRAF mutation, for example, we'll see. Activation of MAP kinase pathway is a feature of most papillary thyroid carcinomas. The most common mechanism of MAP kinase signaling are rearrangement in the genes that encode for RET and anti-RK1, activation of point mutations of BRAF gene जो ऊपर टेबल में दिखाई भी थी. 1/3 to half of the papillary thyroid cancers harbor a gain of function mutation in BRAF. So BRAF is very common mutation. So therefore it is also very commonly tested in exams. Since chromosomal arrangements of the RET or anti-RK1 genes and mutations of BRAF have redundant effects, papillary thyroid carcinoma demonstrate either one or the other molecular abnormality, but not the both. So either this or that, either BRAF mutation or molecular rearrangements. Okay, so papillary cancers, you have to remember these two type of genetic disturbances. Then if we talk about papillary, सबसे पहले इसलिए रखा because papillary was the most common, if you remember. Okay, usually अब इसी sequence में चलेंगे पूरी वीडियो में. सबसे पहले सबसे common की बात किया करेंगे, फिर we'll move on to the other stuff. So follicular carcinomas frequently harbor driver mutations in RAS or in components of PI3 or AKT signaling pathway, and they are both gain of function mutations in PI3 and loss of function in P10. So I mean there is more detail for you to remember. Okay, RAS and PI3 के mutations are found in benign follicular adenomas as well, if you remember my video on adenoma, and they are also seen in anaplastic cancers, suggesting a shared histogenesis. So histological morphology will be similar because the mutation profile is almost similar in adenoma, in papillary carcinoma, and also in anaplastic carcinomas. Okay, 1/3 to half of the follicular carcinomas also have a unique translocation that disrupts PAX8, a paired homeobox gene that is important in thyroid development, and peroxisome proliferator activated, so PPARG, whose gene product is nuclear hormone receptor. Sometimes the translocation has also been known as 1/3 to 1/2 of the cancer. It's a big number. So roughly around 30 to 50% of the patients with thyroid cancers जिनको follicular carcinoma है. So that's a very small attack rate. Small attack rate में इस sense में कह रहा हूँ कि we are not talking about all cancers. We are not talking about all thyroid cancers. We are talking about follicular carcinoma. So of all the follicular carcinomas, about 30 to 50. So it's a very selected population of cancers. Okay. Then we have anaplastic cancers. They're highly aggressive because they are undifferentiated. You cannot even identify कि ये thyroid के cancers हैं. Very bizarre. And ये well differentiated से undifferentiated की तरफ move करते हैं. So these are very highly aggressive tumors, can arise de novo, and they can also arise from papillary or follicular cancers. So papillary and follicular can actually develop into anaplastic. Molecular alterations in anaplastic carcinomas include those seen in the other carcinomas which we just discussed, RAS and PIK3CA, for example. TP53 is also very commonly mutated, loss of function mutation. Then we have the medullary category of thyroid cancer. In contrast to the subtypes described earlier, these neoplasms arise from the parafollicular cells. अभी तक जितने हमने categories की बात की है, they were arising from the follicular cells, but now these are the ones from parafollicular cells, rather than, you see, follicular epithelium. Familial medullary thyroid carcinoma occur in MEN2 type of neoplasia syndrome. आपको पता है MEN2 contains a lot of other cancers incorporated as well. Then are associated with germ-like RET proto-oncogene mutation. Okay, so for everyone you have to remember there are a couple of mutations and a couple of rearrangements that you have to remember. Not only the genetic factors play a role in thyroid cancer, but there are also environmental factors. The major risk factor predisposing to thyroid cancer, listen to this carefully, exposure to ionizing radiation, particularly during the first 2 decades of the life. So this is why We initiated the paragraph with that ultrasounds and imaging is probably increasing the incidence rate of thyroid cancers. Okay, so particularly अगर आप पैदा हुए हैं शुरू के 20 सालों में, आप बार बार किसी भी तरह की इमेजिंग करवा रहे हैं किसी भी वजह से, you are susceptible to get thyroid cancers. In keeping with this finding, there was a marked increase in the incidence of papillary carcinomas among children exposed to ionization radiation after the Chernobyl nuclear disaster in 1986. Nuclear radiations, thyroid cancer. Okay. Deficiency of dietary iodine is linked with a higher frequency of follicular carcinoma. So that particular risk factor is for particular type of cancer. Radiations, nuclear radiations, particularly important because it was observed to be linked with papillary cancer. So these are exam question. Iodine deficiency, particularly follicular carcinoma. Okay. Now papillary carcinomas, अब कुछ अलग-अलग specific characteristics की हम बात करेंगे. As mentioned earlier, so that's the number one most common thyroid cancer. As mentioned earlier, papillary carcinomas are the most common form of thyroid cancer. These tumors may occur at any age, and they account for the vast majority of thyroid carcinomas associated with previous exposure of ionization radiation. So, nuclear radiation, other ionization radiation, it is papillary carcinoma. Okay? What else do we need to know about papillary cancers? Kuch clinical features. Papillary carcinomas are non-functional, so they are not going to release T3, T4 to great extent. Okay, so they manifest most often as painless mass in the neck without any hyper or hypothyroidism type of thing, because these are usually non-functional. Okay, there may also be metastasis, so cervical lymph nodes or other lymph nodes may be enlarged. A pre-operative diagnosis usually can be established by FNIC, fine needle aspiration cytology, based on the characteristic nuclear features described earlier. अभी मैं इस बॉक्स में कुछ स्पेशल orphanary nucleus वगैरह बताता हूँ आपको कि how do you actually histologically identify the papillary cancers. Papillary carcinomas are indolent lesions with 10-year survival rate exceeding 95%. So they are pretty good in terms of survival. Of interest, the presence of isolated cervical node metastasis does not have a significant influence on prognosis. So even the metastasis to lymph node is not changing the story big deal. It's a good survivor rate, okay? In a minority of patients, hematogenous metastases are present at the time of diagnosis. Obviously, in many countries, people go late to the hospitals, okay? And by the time they present to the hospital, most of the damage has been done. The long-term survival of the patient with papillary thyroid cancer is dependent on several factors, including age of the patient. In general, the prognosis is less favorable if the patient is of more than 40 years of age. So, अगर आपको 40 साल के बाद हो रहा है, तो इसका survival rate कम हो जाता है, okay? Presence of extrathyroidal extension, and if there are more metastasis, distant metastasis. So these are all poor factors, poor prognostic factors. Recent studies have shown that follicular variants of papillary carcinoma, so there is a follicular variant as well of papillary carcinoma, although follicular category is a separate category, but within papillary carcinoma, some of the tumor cells may be of follicular variety. So that lack the invasion, essentially no potential for malignant behavior. So these are the good category within the papillary carcinoma classification. In recognition of this, forthcoming recommendations from the WHO suggest the name carcinoma should be stripped from these tumors, which will henceforth be classified as benign neoplasm to prevent overtreatment. So, जो follicular variant है इसके बारे में सोचा जा रहा है, इसको benign label ना कर दें, because ये इतना benign है. So that sort of thing, okay? Now we have to pay attention to some of the histological features, morphological features of papillary carcinoma. Okay, they are usually solitary or multifocal lesions. They can be single, they can be multiple lesions. Some tumors may be well circumscribed, so just like benign tumors, and may be encapsulated. Others may infiltrate. Okay, the microscopic hallmarks are obviously the branching papilla. So you should be able to see somewhere. So you see here, these are the papillary structures. Okay, so you see these papilla. So papillary structure, these are the hallmark of histopathological diagnosis. So there are papilla available. Okay, in most cases, the epithelium covering the papilla has well differentiated, so you can identify this is coming from the follicular cells of the thyroid. They're uniform, orderly cuboidal cell, but more pleomorphic. They have more anaplastic features. They have more mitotic figures, for example. Now that's an important one. Nuclei with finely dispersed chromatin, which impart an optically clear or empty appearance, giving rise to designation the ground glass appearance, because it's through and through, transparent type of thing, or orphan nuclei. So these are characteristic of papillary cancer. If in exam you see this word, papillary cancer is the answer. These nuclear features are sufficient for the diagnosis of papillary carcinoma. So that's more than enough. ये word अगर आपको कहीं सुनाई देता है, pick up the diagnosis. Other important things are concentrically calcified structure known as samama bodies are often also present. मैं भी diagram पे दिखाता भी हूँ आपको. And then there is a follicular variant which is very benign. Okay, so let's have a look at the orphan nuclei. So if you look at the diagram here, you see these are the nuclei. ये nuclei कहलाते हैं orphan nuclei. They're very characteristic of these papillary tumor. So if you see such image, that is what we are talking about. Okay, papillary cancer. The second category obviously is follicular carcinomas, which account for about 5 to 15% of the thyroid cancers. They are common in women, more common in women, and manifest in older age. Papillary at any age, these usually older age, between 40 and 60, not before that. Okay. Follicular carcinoma is more frequent in areas with iodine deficiency. There you go. Papillary carcinoma more associated with radiation, and follicular more associated with iodine deficiency. Right, okay. और इसका incidence कम भी हो रहा है, decrease हो रहा है, because iodine अब salt में दिया जा रहा है, so iodine is no more a problem. Okay. Clinically, these manifest most frequently as solitary thyroid nodules like other cancers. In rare cases, they may be hyperfunctional. So if they are hyperfunctional, they will be releasing a lot of T3 and T4. So signs and symptoms associated with hyperthyroidism and thyrotoxicosis. Okay. They tend to metastasize hematogenous dissemination to different parts of the body, particularly lungs, bones, and liver. And in contrast to papillary cancers, regional nodal metastasis uncommon. ये इनको blood में दूर दूर जाना ज़्यादा पसंद है. As many as 1/2 of the patients with widely invasive carcinoma succumb to their disease within 10 years. Oh, that's not good. While less than 10% of the patients with minimally invasive follicular carcinoma die within the same time span. So it's not a good cancer, by the way. Huh? Follicular carcinomas are treated with surgical excision. Surgery करके निकाल दें. Well differentiated metastases may take up radioactive iodine, which can be used to identify ablation therapy भी की जा सकती है, but surgery is widely practiced. Okay, and some histological features. Most follicular cancers are composed of uniform cells forming small follicles. That's why they're called follicular carcinoma. And if you look at the diagram here, so you typically identify the follicular cells. There are no papillary structures there. Okay. The distinction between follicular adenoma and carcinoma requires extensive histological sampling of the tumor capsule. It's very important because many of the follicular cancers actually look quite alike as the follicular adenomas. But if you look at the capsule very clearly, in this image, for example, the capsule is not there. But if the capsule is looked at very carefully, it will be damaged. And there will be signs of invasion. So that would then give you a hint of being a cancer rather than adenoma. The third category of thyroid cancer is called anaplastic. They are undifferentiated. They are bizarre. They are bad looking. You cannot identify where they are coming from. But by the way, they actually come from the follicular epithelium. Less than 5% of the total thyroid cancer is their rate. They are aggressive, very, very bad, with a high mortality. 100% तक भी पहुंचती है mortality within a few years. Patients with anaplastic cancers are older than those with other types of cancers. The mean age is 65 years. Approximately 1/4 of the patients with anaplastic thyroid cancer have a history of well-differentiated thyroid carcinoma, which usually then converts into anaplastic tumor. Okay? Morphologically, they are bulky masses. You are not usually able to identify it is coming from thyroid, but on careful examination, you may find some foci of papillary or follicular differentiation within the tissue. Okay? Right, so that takes us to the clinical features of anaplastic cancers. They grow with wild abandon despite therapy. So they are very aggressive tumors. Metastasis to distant sites common. And patients usually die within a year. So they are very, very serious. And they also invade the neighboring structures in the neck. For example, trachea. For example, esophagus. So they're very bad tumors, okay? Then we have to deal with the fourth category, which is medullary carcinoma. Is the only one which is not coming from the follicular epithelium. It is rather coming from the parafollicular epithelium or C cells. cells. Like normal C cells, medullary carcinoma secrete calcitonin, and therefore जो भी physiological action of calcitonin है वो हो रहे होंगे body में. In some cases, the tumor cells elaborate other polypeptide hormone as well, such as somatostatin, serotonin, VIP, and these medullary carcinomas arise sporadically in about 70% of the cases, but sometimes, such as in 30% of the cases, they may be familial associated with Men's syndrome. Okay. Both familial as well as sporadic जो अचानक हो रहे हैं या genetics की वजह से हो रहे हैं are associated with gain of function driver mutations in RET receptor tyrosine kinase. Sporadic medullary carcinomas as well as familial cases without an associated Men's syndrome occur in adults with a peak incidence 5th and 6th decade. That's the time frame. Cases associated with Men 2A, by contrast, or 2B, tend to occur in the younger patient. So that's further stratification. If there is a sporadic case that we are talking about, it is more likely to happen in 5th and 6th decade. But अगर men के साथ association है तो फिर early symptoms होंगे. Okay. Clinically, sporadic cases which are not associated with genetic mutations, medullary carcinoma manifests most often as a mass in the neck, sometimes associated with compression effects such as dysphagia, esophagus, hoarseness, larynx. In some instances, the initial manifestation are caused by secretion of peptide hormone, such as diarrhea is the presenting complaint of the patient because the patient is secreting quite a lot of VIP, which increases gut peristalsis and diarrhea and secretions as well. Screening the patient's relative for elevated calcitonin levels or RET mutation is usually also done, particularly for familial cases, obviously. As discussed later, all members of Men 2, chondrites carry RET mutation. They are offered prophylactic thyroidectomies to preempt the development of the medullary carcinoma. So it's like, पहले से जहाँ गड़बड़ होनी है वो organ निकाल दो type of thing, right? The only histological finding in the resected thyroid of these asymptomatic carrier is the presence of C-cell hyperplasia, because ये अभी तक tumor बना नहीं है, आपने पहले निकाल दिया. Okay? Now let's look at the histopathological appearances. Medullary carcinomas may arise as a solitary nodule or maybe multiple lesions. Multicentricity is a particular common phenomena in familial cases. Large lesions, so that's not for you to remember. Amyloid deposits derived from the altered calcitonin molecule. So you see a lot of amyloid. This is specific about this particular category. Okay. That's all. We then will start parathyroid in the next video, but thyroid gland is done now. And we talked about hypothyroidism, hyperthyroidism, tumors of thyroid. So, the thyroid gland has been well covered as far as the pathology is concerned. So, अब आपसे अगली वीडियो में बात होगी about the parathyroid glands. My name is Professor Asif Qureshi and you are watching Dr. Asif Lectures.